Welcome to the epic conclusion of the best TV medical drama of all time, The PITT. My name is Dr. Taylor. I'm a full-time practicing emergency medicine physician, and this is Dr. Taylor Reacts. If you're new to my channel, welcome. If you're returning, as always, thank you so much. I can promise you this channel is going to give you the most detailed critique, analysis, breakdown of The PITT on YouTube by any ER doctor. Nothing will come closer. I can promise you that. Here it is, episode 15. Let's finish strong. Let's go.
Whoa, what's going on here?
I disabled my ankle monitor because it was going off and fucking with our ability to help patients during the mass casualty.
Tell that to your judge. This is my resident. I need her. Call Gloria. Can you at least wait a second, speak to our chief medical officer?
No, but they can call the department if they have any questions.
We just came through the worst mass casualty incident in this city's history, and you two are fucking around with this? Are you serious? You don't have anything better to do? Officer Harrelson, can you please?
Is there a problem here?
She disabled her ankle monitor.
It was malfunctioning.
She's in a custody battle with a restraining order and is considered a flight risk.
That's bullshit.
You're interfering with our ability to treat patients. I'm not sure we could have saved Officer Stefano if she hadn't disabled the damn thing.
That true?
They saved Stefano's life. He saved a lot of lives.
Take care of this first thing tomorrow morning.
I swear.
Take the cuffs off.
Thank you.
Thank you.
Thank you for everything you did here tonight.
Priorities, priorities, priorities. That is what I have to say about that. This is one of the physicians helping your fellow officer in the middle of a mass casualty incident, and you want to just arrest her and take her away. Come on, guys, like situational awareness. Like, just call your supervisor, discuss this case. Yeah, she tampered with the device. It's illegal. You can't do that. But, you know, this is a different situation. This is the largest mass shooting the city has ever seen.
Do I even want to know?
Probably not.
Good. What's your status down here?
We have had 112 mass casualty patients come through here in the last 3 hours. Only 6 people that we couldn't save. They're still in our makeshift morgue and peds. 71 people went upstairs last I heard. Surgery had stabilized the 39 most critical red zone, 32 pink zone patients. We also had 24 yellow zone patients, many of whom are getting orthopedic surgery as we speak. The police are still interviewing. Everybody else is still down here. We discharged 8 people, and I don't know the status of the green zone patients because I wasn't there. You'll have to check with family medicine.
Impressive. I need you and Abbott to turn your patients over to the night shift now. And then, oh, sorry. Hello. What? No, we need to be back up and running now. Tell security to open the ER doors for walk-ins. If you've got a triage nurse and registration clerks, you should already be open.
You ready to give this measles kid to Dr. Shen and go home?
Oh, no, I'm okay.
You sure?
Yeah. It's just, we repeatedly tried to explain the importance and low risk of the spinal tap. And the parents they're risking their son's life.
Hopefully they'll come around.
And if they don't,
We do the best that we can. Some things are out of our control.
Dr. Robbie asked if she wants to give this patient to Dr. Shen and go home. Dr. King obviously has a strong connection with this case, partly I think because the interaction with the patient's little sister. Now, she wants to stay, which is realistic, that happens. I just had a case the other day, came into my shift with only 5 minutes remaining in picking up patients. It was a massive beta blocker overdose that would ultimately require intubation, numerous meds, numerous drips, toxicology consult, and admission to the ICU. Certain cases you just want to finish yourself, while other times it's best to sign those cases out as you may be well past that fatigue point, that fatigue factor. You're literally at the end. Your mind is no longer thinking the same, and that is when things get dangerous. Dangerous things can happen, and the risk is higher.
Dr. Shen, how are we progressing in here?
No improvement. The patient or his family?
Where is your wife and daughter, Mr. Edwards?
My wife took Georgia to the bathroom.
Okay. Well, your son Flynn is critically ill. And the longer that we wait, the worse this could get. Without the spinal tap, we don't know the best treatment to give him the best chance of recovery.
What's going on?
We were discussing the options for treating your son.
He already looks better.
He is not. And by refusing the spinal tap, we don't know how to help him.
She states he already looks better. Where in your Bachelor of Science degree in Google search studies did you learn that? If in terms of looking better is the fact that maybe he is not cyanotic appearing because his oxygen was so low and he looks better, but that's because he's intubated on a ventilator, 100% FiO2, he's no longer hypoxic. But we know that's not what she's referring to. He's not any better in terms of his diagnosis. He's sedated on a ventilator in acute hypoxic respiratory failure, secondary to pneumonia, possibly complicated by acute disseminated myeloencephalitis as well, with a near 20% mortality, 1 in 5 chance he's going to die. In an unvaccinated pediatric patient, and you have the guts to tell the treating physician he looks better. No, Karen, he doesn't look any better at all.
The steroids could kill him. If it's just pneumonia, the steroids could save him if it's ATEM. And the longer that we wait, the greater the risk of him dying.
We might die.
No, honey, he's just got a worse version of what you had.
I'll keep him intubated, hydrated, and pumping the antibiotics. I'll let you know if anything changes.
Mr. Edwards, may I speak with you outside, please?
Go. I've heard enough.
Tell me about your son.
He's a great kid. He's kind. He's very good to his little sister.
You too close?
Yeah, not like my old man.
Samira, finish up.
He was not around very much. Didn't really care what we were doing.
Does Flynn play any sports?
Baseball, soccer, basketball.
David?
My wife doesn't want him playing football, or he'd be doing that too.
Do you get to many games?
I'm doing my best.
Pick identification.
What the hell is this?
These are the people from the Pit Fest shooting that we couldn't save today. We couldn't save them. But we can still save your son.
You're an asshole.
Yeah. I'm an asshole. I was trying to save your son's life.
Well, this is an interesting way to get a point across. Dr. Robbie wants him to talk about his son and then proceeds to show him the morgue. Obviously, names and bodies are covered up to protect patient privacy, but seeing something like this may just be enough to realize how sick your child is and what could happen if you continue to go against the advice of physicians treating him. Now, I can't say I would do this, but it is one way to really bring home a reality check. That is for sure.
Charge for 2 patients in North, 3 in South.
All right, we're on it. Just give us a hot minute. Hey, Leanne, can you check out the one she's talking about?
It's a co-tan. Illness or injury in a public area of the hospital, usually a fainting or a fall. Hey, Gloria wants day shift. Get out of here sooner rather than later, so wrap it up.
Gotcha. Repeat labs back on our Blue Man Max, running through agents that cause methemoglobinemia, mainly drugs and toxins.
Drugs like topical anesthetics from the dentist, antibiotics to treat malaria, leprosy.
Okay, I can see if he's taking any of those.
Also ask about industrial toxins, aniline dyes, benzene. There's also food additives, nitrates, nitrites.
Some of those are available online as suicide kits.
I think he may have tried to hurt himself.
Maybe. Or he was poisoned. I had a guy today whose wife was spiking his coffee with progesterone.
Jesus, and I thought the crazies were for the night shift.
She wasn't crazy, just desperate.
Help! Police! Officer, I'm being held here against my will.
What else do we know about him?
Nothing, really. He was too groggy to talk, but I can give it another shot.
Go for it, Sherlock.
Will do.
She is researching here things that cause methemoglobinemia. But I would argue, frankly, it does not really matter at this point. The treatment is the same. It doesn't matter if it was this or this or this that caused methemoglobinemia. The treatment's still the same. They still need methylene blue. Now, once that patient has been given methylene blue, they're getting admitted to the ICU. We're not just keeping them in the ER. If they need a second round of methylene blue, the ICU can manage that. Now, maybe the ICU is full, who knows? In reality, we were playing detectives at finding the diagnosis, but we aren't necessarily playing detectives in terms of finding out what the patient took that could have caused it. The admitting team can research that further. Even if it was a substance he took to kill himself, the ICU can manage this further. Now, you need to move patients, especially in a mass casualty incident. That's what I'm targeting with this particular critique, is the fact that you need to move patients in a mass casualty incident. We see it here, though, for more of a dramatic appeal. In real life, this patient's going to be in the ICU. The ICU team is then going to play detective further. You can express your concern to the admitting team at that point, and they can take over. But we all know they don't really incorporate outside resources or outside consults besides, a few of the ones that we've talked about. We really don't see other specialties besides, we'll see ortho or we'll see trauma. Like, there's a few things we'll see, but, we haven't seen ICU at all. I think it would take away from the TV series, which is why they're not doing it. But in this case, that's why we're having her play detective, keep going back in there, asking all these questions. But in reality, this patient's going to the ICU. They're going to need that second round of methylene blue. If they need it, then ICU is going to do it. All right, you have to move patients. This is a mass casualty incident. Now, if it wasn't, sure, keep that patient in the ER for 3 or 4 hours. Keep playing detective. Keep doing that because you have room. Another example would be a patient that comes in with bilateral ankle fractures, lumbar burst fracture, 3 broken ribs, small pneumothorax. Their alert and orient time's 3. They're still talking to you, and they state, "Doc, I fell off a ladder." Once we have our diagnosis and treatment started, that patient's admitted to trauma. Turns out this is actually a suicide attempt that the patient admitted to hours later. Psychiatry saw him. But we weren't just going to keep him in the ER until he confessed. That's not how this works. Only critique with this scene. However, that being said, they needed Dr. Santos to try to find the cause, as that led to her telling us her story, the patient admitting to that this was a suicide attempt, and then for wanting help. So it's great to see all this, but this patient would already be in the ICU, not the ER, especially in a mass casualty incident.
Last thing, patient going upstairs.
You two hanging in?
Oh, yeah.
Okay, start wrapping it up and then hand off what you have left to the night shift.
Can we talk?
Go home. I don't want to tell you again.
You needed me.
Do you have any idea how much trouble you're in?
Only if you report me.
I'm gonna pretend
Robbie,
that I didn't.
pelvic crush injury.
Don't even think about it. Thought we were close to trauma.
This is the code tan. He got pinned behind a truck backing up with replacement supplies.
100% non-rebreather. Let's drop 120 ketamine, 100 of rock, and page trauma surgery, please.
Where the hell this guy come from?
Our loading dock.
Okay, I got the E-Fast, grab a binder. Obvious pelvic fracture.
This individual was pinned behind a truck. Some of the worst injuries can be seen with this kind of mechanism. Now, just as the gurney went by, we hear very subtly, but pulse weak. So already in this instance, I'm thinking, all right, patients in hemorrhagic shock, hypotensive tachycardia after a pelvic crush injury. All right, when you see this, my mind is going really to the top 2 things. This is an open book, and there's probably a sacroiliac joint dysfunction. All right, these are worst case, and they're bleeding into the pelvis. This patient needs a lot of stuff done over the next few minutes. When I hear this, again, the focus is immediately going to that pelvic binder, getting him in the trauma bay, and starting that resuscitation. We hear Dr. Robbie say 100% non-rebreather, 120 milligrams of ketamine, 100 milligrams of rocuronium, and then Dr. Abbott mentions E-Fast binder. A lot of info given all at once. That ketamine or rock is for intubation. The amount of pain that somebody would be in with an open book pelvic injury and then having to place a pelvic binder and tightening that thing would result in significant pain. You want to hear somebody scream? Don't give them pain meds and tighten that binder. When I was still a resident, they were tightening the binder on one particular patient. I was an intern. They were tightening the binder, and the nurse hadn't actually pushed the dilaudid yet, and you just watch this guy just scream. Now, this patient's going to need the OR anyway, so just intubate him now. Just be aware of the hypotension and tachycardia the moment you intubate. That post-intubation hypotension can lead to a cardiac arrest. So again, it's a delicate balance between RSI, more of a delayed sequence intubation, like you're trying to decide when you want to intubate, what do you need to give for the pressure, at least temporarily. Ketamine can do a few things with that. Do we want etomidate instead of ketamine? There's so many different things at play here. The only reason I wanted to mention a few of those is just because of the hypotension and tachycardia. The moment you intubate, that patient could decompensate. So what are the indications for a pelvic binder? Per the Department of Surgery at McGovern Medical School, any open book pelvic fracture despite hemodynamic status, a patient with a suspected pelvic fracture or hemodynamic instability where pelvic films are not available. So when we place this pelvic binder, we need to make sure we actually place it correctly. Sometimes patients come in via EMS with a binder on. Other times that binder is placed in the ER. But regardless of how that patient arrives to the ER and what happened, that binder needs placed correctly and it needs placed immediately. The pelvic binder should be centered over both the left and right greater trochanter. There are certain instances we don't place a pelvic binder, so it kind of depends on that situation and hemodynamic stability of the patient. So I put an asterisk next to this one, but lateral compression fracture patterns can actually be worsened by the inappropriate application of a pelvic binder. I'm not going to get into times that we don't place a pelvic binder. That's a whole different lecture, but it does overall depend on the situation, the hemodynamic stability of the patient, and what type of fracture there is, what's that fracture pattern. That's why I put an asterisk next to lateral compression fracture.
I'm in a lot of pain.
You taking any medications? Any drug allergies?
No. Am I gonna be okay?
The only thing unrealistic about what we just watched was that he placed the binder, tightened it, and the patient did not flinch one bit. Hello, didn't you just hear the story I mentioned of what happens if you tighten that without pain meds? Again, someone would be like, oh, he mentioned ketamine, he mentioned rock. Again, those are for intubation. In real life, if you do this without pain meds on board, that patient is going to scream. This is extremely painful. When they mentioned earlier ketamine or rock, again, that ketamine can be used for pain. You can use ketamine for pain. But that's also not the pain dose ketamine, that's the intubation dose ketamine. The amount they mentioned would not be a pain dose, and I'm not gonna get into pain dosing of ketamine. Maybe for season 2, they actually want to mention pain dose ketamine, and I'm gonna critique it hard for accuracy. But again, they gave the intubation dose. Now, the patient has a weak pulse, implying blood pressure is low. It's a delicate balance. Again, I just mentioned this, between hypotension, shock. You wanna give pain meds, but then you need to decide when you want to intubate. So again, it's a delicate balance between I need something now and I need to get that binder on.
Absolutely.
We got you, Hector.
BP 68/42, pulse 130. I got a 14 gauge in the left AC.
Whole blood massive transfusion protocol.
We got whole blood coming in from Erin Youngstown. I'm not sure it's here yet.
Let's go 1-to-1-to-1, red cells, platelets, and plasma. We've got that.
So now we have our very first set of vitals, 68/42, heart rate 130. Patient is in shock. But we already knew that earlier when we heard pulse is weak. You do not need to know a blood pressure to know when a patient is in shock. In a clinical setting, in a battlefield setting, you're going up to somebody that just had a GSW or just was crushed by a vehicle and they have a thready pulse, diaphoretic, like they're in shock. You don't need a blood pressure for that. I'm glad we have it now. I'm glad we have our first set of vitals, but I just wanted to put that out there. We do have a 14 gauge IV in the left AC. We do need at least one more line for good access. We're activating the massive transfusion protocol, which is perfect in this situation. This patient needs blood. We have the binder on so far, solid. We just need a little bit more access.
Let's place an IJ after the intubation, please.
On it.
Dr. Robbie states IJ after intubation. The reason for that is the binder is actually over that greater trochanter on the left and that greater trochanter on the right, so that just eliminated placing a cordis to that left femoral or right femoral vein. So the plan is, after intubation, to place a central line in the internal jugular vein, which is honestly perfect. I did that numerous times. The thing I love about this case is that you have two attendings working the case together. In residency, some of the best cases, some of the biggest cases like this, when you have a few residents on and the attending, it is awesome. As an attending currently, it's not often that you actually get to work a resuscitation like this with a couple ER attendings. When you do get to do that though, it is awesome. Had one the other day, one attending was intubating. I was placing a femoral cordis while trauma was placing a chest tube. Literally 3 procedures being done simultaneously by 3 attendings. Everything was done in under just a minute. So when you get to work together in the ER as a team like that, it truly is amazing. That's what I really love about this scene.
Okay, EFAS negative, it's all retroperitoneal. No blood at the meatus. Passifoli.
Hector, You crushed all the bones in your pelvis and you've got some internal bleeding. We need to sedate you to treat you.
Hurts a lot.
When you wake up, you're not going to be able to talk. You're going to have a breathing tube in your throat.
Can I speak to my wife first?
Afraid we have to move now, Hector.
First unit, pack cells in the infuser.
What have we here?
It looks like two old white guys poached our patient.
Oh, I know you're not talking about us.
Well, I know he's not talking about me. Crushed pelvis, hemorrhagic shock.
NTP, pelvic binder. I'm doing an intubation about to place an IJ.
You need us?
We got this for now. Hold down the fort, get caught up on the day shift's remaining PITT Fest patients, and we'll get this guy stabilized.
How you feeling, Max?
Now, it's pretty fast on screen, but Dr. Robbie intubates directly with a Mac blade. That ET tube has a soft stylet, legit, looks real. Honestly impressed. Throughout the episodes, we see various times where they're intubating with the glide scope and that ET tube has a soft stylet, or that glide scope and ET tube has no stylet. So to see it done here correct on episode 15 is perfect. Love it.
Yeah, I'm all right.
So we are treating you for methemoglobinemia. Have you taken anything or eaten anything out of the ordinary lately?
No, just some unhealthy food truck choices.
Okay. Do you work around toxic chemicals?
No, I'm a graphic designer.
Have you had dental work done lately? Used topical pain relievers?
No.
Do you know anyone with leprosy?
Leprosy? Yeah, I don't know anyone with leprosy.
Well, something that you ingested or came into contact with made you really sick, and you could have died. So we need to figure out what caused it so it doesn't happen again.
It won't.
Is there anything else going on in your life that you want to talk about? Anything causing you undue stress or worry?
No. I think I just need a little rest.
All right. Well, I will be back.
We want patients to be honest with us, but at the end of the day, they have the choice. Up to this point, regardless of what he took, the important thing is that he's stable and he needs admitted.
This has to be the slowest elevator in the world.
You in a hurry to get back down there?
Still a backlog of cases to check on.
Our shift was over hours ago. You don't want to go home and sleep?
I hope this didn't turn you off of practicing emergency medicine.
Pretty sure today turned me off practicing all forms of medicine.
Everything will be a cakewalk after today. I promise. Come on, let's go find a good case.
Yeah. I'll be right there.
What Dr. Mohan just did is spot on. I love this. In residency, I would even argue that as an attending as well, there are times when you're past your shift, but because of an adrenaline rush, you get that second wave of energy and you feel like you can take on the world and take on one more case. You need to be aware of that though, as picking up another case at that point may not be a good idea. Such an intricate detail for the PITT to utilize here. No other TV medical drama would have incorporated such a small detail like this. It is impressive.
You can't shoot the film.
Clear for X-ray. Shooting. Clear.
Now, I told you I'm going to stop every single time. I'm even going to do that in season 2 when we see this, because I think it's very important. In the very start of the PITT, all these critiques initially early on, they didn't really show an x-ray machine at all, any portable x-ray machine. Decisions were being made constantly with ultrasound and no x-ray. So again, I'm going to stop every single time and point this out. Here we're getting an x-ray to both confirm ET2 placement and that right IJ central line placement did not result in a pneumothorax, in addition to a pelvic x-ray to take a look at that fracture. That is pretty normal, all right? Getting a chest x-ray portable, pelvis x-ray portable are very quick. These get done very fast, especially when you get a bed that's a trauma bed, all right? You can get these x-rays very, very fast.
Oh, that ain't good. You got widened symphysis pubis anteriorly. Disrupted sacroiliac posteriorly. Guy's bleeding like a stuck pig.
All right, so the x-ray they got of the pelvis is perfect, but where's your chest x-ray? It would have actually added more to this case in terms of the realism. Typically in a trauma setting like this, again, we're getting a one-view chest x-ray. We're checking that endotracheal tube placement. That is normal after intubation. Sure, you're listening to bilateral breath sounds confirming that you're in the lungs and the patient's not currently satting 50%, and you're like, I don't hear lungs. You're checking ET tube placement, and then every single time you're placing an internal jugular vein or a subclavian vein central line, you're getting a chest x-ray to both confirm placement and to make sure, one, you're in the right spot, but that you're not you didn't cause a pneumothorax. That is normal here. We are then getting a one view of the pelvis looking for that injury. Now, what they could have done here is add a quick chest x-ray to make this more realistic. In fact, all the PITT had to do was maybe make Dr. Robbie state, right after the portable chest x-ray, all right, ET tube is 3 centimeters above the carina, looks good. Dr. Abbott, the central line, right IJ, looks appropriate position. I don't see any pneumothorax here. All right, let's go ahead and shoot that pelvic x-ray. And then now we get to see the pelvic x-ray. So small critique there, small detail, but that would have made it more realistic. I got super excited when I saw the x-ray machine, because again, early on, you saw it a few times. At the very beginning, you didn't see it at all, and then you saw it a few times. And then to see it again, and then they just skipped the chest x-ray. Maybe they just already did the chest x-ray, they didn't show it, and they just showed the pelvis x-ray. That's fine. But I do think it would have added more to the situation, especially for teaching, if they would have explained it how I just did. Now, me looking at this x-ray, I'm not a radiologist, but me looking at this x-ray, I'd say we have an open book pelvic injury with a left unilateral SI joint disruption. That diagnosis itself results in massive hemorrhage into the pelvis.
I got Dr. Walsh on speakerphone from the OR.
Hey guys, what's up?
We've got an unstable pelvic ring fracture systolic of 68, eat fast negative.
I thought we were close to trauma.
Hospital worker versus reversing supply truck. MTP and pelvic binder in place.
The stethoscope is on correctly. Love it. I just wanted to pause for that reason. Whoop, whoop.
PXA?
Gave it.
Stable for CT angiogram?
Not at the moment, no.
Keep transfusing.
The surgeon asked if the patient is stable for CTA. No, Dr. Walsh, didn't you just hear them say the patient's blood pressure is 68 systolic? Anyway, that patient's clearly not stable enough for CAT scan. She is in the OR operating, so maybe she didn't quite hear that part. Partial credit overall.
The blood bank is still waiting on a delivery unless you have some upstairs.
He doesn't need surgery. He needs interventional radiology to embolize the bleeders.
They don't like unstable patients.
They will tonight. I'll be down as soon as I finish this grade 5 liver lock. Hodges, wrist shrapnel. Check.
Malloy, leg shrapnel.
Yeah.
Montgomery, abdominal shrapnel.
No. This is supposed to be Chu, female with a headlock.
Great. So where the hell she go? Dr. King, Whitaker, there's supposed to be a female Asian patient with a headlock in this bed.
Yeah, I don't think that's her.
Right. Whitaker, I need you to find the patient that's supposed to be here. Chu, elderly female with the headlock.
Me?
I saw you caught that rat. Did the closest thing we got to a bloodhound. I mean that as a compliment.
Hey, is this a good time?
No, I got a missing patient. You seen a woman with a scalp black last name Chu?
No, but I need to talk to you.
So talk. You treat a woman with a scalp black named Chu?
Doesn't ring a bell.
You're a lot of help. Start wrapping up and get out of here.
Gladly.
In private.
Keep looking. I'll be with you in a minute. Okay. What the hell? I feel like I'm gonna sleep tonight anyway.
What have you been hearing?
I was screaming and crying. Got a feeling that's gonna stick with me for a while.
I mean, about me.
Doctors. Always with the me. Heard you went home early, but you came back, so cutting you some slack this time.
Why? Why'd I go home?
Just figure you're being a pussy.
When did Robbie tell you? Dana.
He said I didn't want to know, so I didn't ask. In trouble, kid?
No, it's just a stupid misunderstanding.
And no worries, misunderstandings can be sorted out. Look, everyone's nerves are frazzled from today. Just go home, get some rest.
Robbie believes something that's not entirely true.
That's not like Robbie.
I need you to have my back on this.
Look, I love you, kid, but this sounds like it's between you and Robbie and above my pay grade. Hell, I'm not even sure I'm ever coming back after I walk out here tonight. Fuck.
What are you talking about?
I'm done. Get too old for this shit.
What? No, Dana, you can't quit. It's like the fucking world is imploding. Dana, you can't quit. We need you. Robbie, me, everybody.
We see this throughout the entire season. Burnout is real. Nurses and physicians are leaving emergency medicine. So per the American Medical Association, emergency physicians serve on medicine's front lines and have the burnout rates to show for it, topping the list of specialties with the highest level of burnout, with 56.5% doing so in 2023, according to exclusive AMA survey data. Now, in another article published in the Annals of Emergency Medicine entitled Burnout, it states, emergency physicians experience professional burnout more than 3 times that of the average physician, according to a national study that compared burnout rates among specialties and with workers in other fields. Now, on the nursing side of things, all right, we're going to focus on that now. On the nursing side of things, an article published in the Journal of the American College of Emergency Physicians Open, entitled The Association of the Emergency Department Work Environment on Patient Care and Nurse Job Outcomes. Researchers out of the University of Pennsylvania did a cross-sectional study of 221 hospitals in New York and Illinois. Surveys were from 746 emergency nurses and 6,932 inpatient nurses, with linked data on hospital characteristics from the American Hospital Association's annual survey. They found a total of 58% of emergency nurses reported high burnout. 39% reported job dissatisfaction, and 27% indicated intent to leave their job in the next year. All these numbers are alarming, and for the PITT to address burnout just shows us kind of that realistic nature of the PITT.
Just gotta wrap things up and get out of here.
I need you to vouch for me. Robbie thinks I'm a fucking drug addict.
Are you?
No. No, what I am is scared, okay? I'm really fucking scared of what happens next. I fucked up, Dana. I fucked up, and I don't know what I'm supposed to do.
You're a smart kid. You figure it out. Trust Robbie, okay? He'll do what's best for you.
What's best for me is being a doctor.
Hey, no luck finding Mrs. Chu.
All right, I'm coming. Sure.
Yes.
How's he doing?
Same.
So he's not getting any worse?
Not at the moment.
Our family physician is making arrangements to move him to West Penn.
The family physician is making arrangements to move him to another hospital. Hello, Karen. That is not how that works, and no, you're not, and no, that family doc is not either. That family physician has no authority whatsoever and no ability to do that at all. This is an ER patient at this hospital. The only way to transfer this intubated patient is for the ER provider at this hospital to discuss the case with an ER doctor or ICU attending at another hospital, and they have to accept the transfer of that patient. Just because, Karen, you say the family doc is making arrangements here is so fake, it's ridiculous. It almost makes me question the physician on the other end of that line of her phone call. Any family physician would know that this is not possible, and it's not their call to make, and it's not their patient at that time. For the patient to just leave would be an EMTALA violation, a heavy EMTALA violation. I do not say that lightly. The part I'm critiquing with this is how would something like this even have made the cut for the PITT when it comes to physicians reviewing the script for accuracy. What Karen stated here was inaccurate and wrong, and that's not how things work. This is much different in a non-intubated patient, a non-critically ill patient in terms of options. We're going to talk about that in a minute.
Will you excuse me for a second?
Or after 3 rounds, packed cells, FFP, and platelets.
We hear them listing blood products the patient has already received as part of the resuscitation. We also see that the binder is on. The vitals on the screen are just for a split second, but I'm going to put those on the screen for you. I watched this back a few times just to identify what those were. But that blood pressure is 92/54, heart rate's 120.
Not too
Our
shabby.
measles kid's parents are trying to move him to West Penn.
Let them. They've been warned multiple times. I even took the father into the Pit Fest morgue to drive the point home.
You what? Yeah, I doubt any hospital will take him without a spinal tap.
Dr. Ellis states, I doubt any hospital would take him without a spinal tap. Definitely a possibility here. If you discuss this case with another hospital and speak with an ER doc or an ICU attending, they're going to ask you about the LP results and if we performed an LP. Now, it is one thing to be at a facility, small ER, intubated patient, you don't have any LP kits, or the facility you're at is so small that you can't do an analysis of CSF, and certain labs like that are actually a send out to another hospital. You have to wait 2 or 3 hours for a courier to show up, they pick it up, they drive 2 or 3 hours, they go drop it off, and it runs. That's possible. I've been at those facilities. I know how that works. I've had that same situation. It's another thing entirely to be at a facility like the hospital on the PITT with all the resources they have, and the patient is already at a high level of care. They're already at a higher level of care. A lot more at play here in terms of just EMTALA. It's also hospital policy, lateral transfer, stability of the patient, etc. that I'm not going to talk about. Yes, patients have the right to request transfer, but what I'm talking about is that when Karen says the family doc is arranging transfer, that's wrong, and that's not how things are done. And frankly, it means nothing. I find it interesting that Dr. King comes in stating to Dr. Robbie, they're going to try to move him to another hospital. They can't do that. It's an intubated patient. The family is not just going to grab the patient, grab a bag off the wall, and start bagging the patient, put them in the car, the patient's intubated. Like, that's not going to happen. They can't do that. It's an intubated patient. This entire thing is an ER attending to ER attending phone call, or an ER attending to ICU attending phone call for the accepting physician. You may say, well, the family doctor may be the accepting facility at my hospital. I would argue this is an unstable intubated patient. The ICU would be the accepting physician. The family doctor is not going to be the accepting physician for an unstable intubated patient into the ICU. It doesn't matter if that ICU is a closed ICU or if it's an open ICU. When you're doing this, regardless of how that patient's potentially going to go to that other hospital, they're going to be in the ICU. The ICU would be consulted. It would be the ICU accepting them. So overall, this is not a family physician situation. So I guess I don't understand how this made the cut, how the reviewing physicians that literally went through this script said, you know what, let's just have them try to take the patient away, and let's mention the family doc's going to try to arrange transfer, and then you have this Dr. Shen, brand new attending, that's going to say make sure they don't leave. It's like, what? Like, what's going on here?
I'll be there in a minute. Don't let them move that kid.
Don't let them move that kid. Oh, I'm so confused. Who is moving the kid? I am not sure what's happening with the consulting physicians, again, regarding this series of events with this episode. Dr. Shen, an attending, is worried someone's just going to come steal the patient, that EMS is magically going to avoid all their protocols and all of their policies and pick up a patient and take them to another hospital without an accepting physician. No, the hospital would suffer multiple heavy EMTALA violations. This entire scene is definitely dramatized. That patient's not going anywhere. He's intubated. It's one thing if he was not, again, patient stable, AO3, family wants to sign the patient out AMA, they walk out and they drive to another hospital and check in there. That's a different situation entirely. That's not an EMTALA violation at all. They left AMA. That's a whole different situation, but that's not what the PITT is doing here. So again, this is a ER physician to ER physician phone call, or an ER physician to ICU attending phone call. Now, you have to have that accepting physician. Do we transfer patients to another hospital after they're intubated? All the time. It happens. Patients come to your hospital, they're in distress, they're intubated, but all their care is at another hospital, or the family just wants to go to a different hospital. That's fine. All right, we go through a transfer center, we make the phone call, we discuss with the ER doc, or like they're already intubated, so they're in the ICU, we discuss with the ICU attending, depending on who's accepting at that particular facility. We have that conversation. Yeah, you can go ahead and transfer, we'll take the patient. That happens all the time. In this situation, it's a little bit different because whoever you call is going to say, what's the LP show? And they're probably going to ask you to have that discussion again with the family, letting them know if that patient, based on that history in physical exam, comes to their ER, they're also going to recommend an LP. If somehow they get to be a direct admission to ICU, they're going to undergo an LP. All right. Now, can family continue to refuse LP? Yes. But at the same time, it's also the physician at the other end of the hospital. Again, I'm not talking about all of the other intricate details of EMTALA. I'm not talking about high or low level of care in terms of transfer. And I'm not talking about lateral transfer here. I'm just staying very, very broad. But just know there would be a lot of EMTALA violations with this patient just randomly leaving to another hospital intubated. So again, I think the PITT just need to change a few things.
Okay, great. Thank you. I can see this guy in 45 minutes. An interventional radiology.
That's a long time for this guy.
They're just starting a REBOA.
You did a REBOA during the mass casualty?
One of his interns did.
Shut up.
I was busy.
That was ballsy. Yeah, we can babysit this guy until IR is ready. You guys are 3 hours before shift.
This was supposed to be my day off. We got this. Hasta la vista, vatos.
Hey, have you seen an elderly woman with a headlock last name Chu?
No, sorry. Our shift is over.
Dana asked me to find her. Said I'm the department bloodhound now.
Well, you did catch the rat.
Hey, have you seen an elderly woman with a headlock last name Chu?
No.
Okay.
Anything interesting up here? Oh, we are off the clock.
I know. It's gonna take a couple more hours to get caught up on every patient.
Are you feeling okay?
I feel great. Better than great. Today was horrific, but we got through it. We did some amazing things. Like, I drilled a burr hole with an easy IO.
Yeah, that was something. You should probably go home now.
I'm good.
No, you're running on an adrenaline high, and you are going to crash soon, trust me.
Rather be here.
This job can't be your life, Samira.
It's not. What, because I'm not in a relationship and I don't like socializing after work? All that other stuff can wait until I finish my residency and get to where I want to be in my career.
Yeah, for sure.
Hey. I love my life.
The adrenaline rush after a good case is real. You are exhausted, you're wore out, but then you get this awesome case that comes through. Patient does amazing. You get them admitted to the ICU. Now what you're left with is the remaining part of that adrenaline rush, that last little bit of that adrenaline rush. Now you can't sit still. You don't want to leave. You don't want to sleep. Yesterday I was doing an afternoon shift, finishing at 2 a.m. Big case comes in, trauma 1, multiple gunshot wounds to the arms, the chest, and the abdomen. Patient's intubated, bilateral chest tubes, trauma cordis, massive transfusion protocol. They went to the OR. Say bye. They went to the OR. Shift is over. Room's a mess. Blood's all over the place. You're still riding that high from that adrenaline rush. You sit down at your desk to chart, you could still feel the adrenaline rush. Like it's still going. You're like, man, I got to go do something else. At this point, you'd be tempted to be like, oh, I'm going to work a few extra hours. I'm going to stay till morning, maybe pick up one more case. That's the mistake. You cannot maintain that same level of adrenaline at the end of the shift. Sooner or later, you're going to crash. And you don't want to be in the middle of another case when that happens.
Our Blue Man Max needs a psych eval.
Based on what?
No health reason for taking anything that could have caused this. No exposure to anything in the workplace. He didn't ask me to call anyone. Just worried he was trying to hurt himself.
It's a stretch, new girl.
But he's also not asking to go home. I mean, if this was a failed suicide attempt, it makes sense that he's too frightened or embarrassed to admit to what he did and too afraid to go home because of what he might still do.
Okay, I'll call Psych. We'll find someone to take over for you. Your shift ended a couple of hours ago.
I'd like to try and get a little more out of him, see if I can get him to confess to something.
I've seen your bedside manner.
Okay, that is reserved for assholes. I don't want this kid slipping through the cracks.
Okay.
Thanks.
Thanks for letting me come back. I didn't let you come back. You came back on your own, and I let you stay. Figured it was one time throwing my career away was for a greater good.
I was never high. I was just treating my own withdrawal symptoms.
Well, you should have done that under the care and supervision of a physician.
With that on my record, I could have my hospital privileges denied whenever I apply for a job.
No, that's not true anymore. That's not true anymore. You could have come to me. Instead, you could be arrested on felony charges for stealing controlled substances from the hospital.
Robbie, I could lose my medical license. Come on, man. You never heard of second chances.
Here's your second chance. 30-day inpatient treatment program, followed by random urine tests, 50 to 60 a year, followed by mandatory NA meetings 3 to 4 times a week for the first 3 years.
3 years?
Of a 5-year program. You need help.
What about you, man?
Take the rehab, man. It's better than the alternative.
What about you? I'm not the only one who's a little fucked up here, Robbie. Why don't you look in the mirror?
What's that supposed to mean?
I never had a complete meltdown.
No, you just cause them in other people.
You're blaming me for what happened to you.
What happened to me? What happened to me?
Yeah.
Oh, you are so full of shit. You let me down. You let everybody down, especially yourself.
Someone saw you in peds.
Who, Whitaker?
No. A night shift nurse. Saw you on the floor, said it looked like...
Look like what? Look like what? This job will fuck you up if you let it. You let it.
Yeah? I wasn't the one talking to cartoon animals and peds.
Fuck you!
Doing okay, man?
Why do you keep asking me that?
Oh, I don't know. We did take the parent of a patient into our makeshift morgue. Forget that it's technically a fucking crime scene. That's just not cool, man.
Just the two heroes I wanted to see. We're holding a press conference in the education auditorium.
Not a chance.
I know you hate this stuff, but it's important for this department and the hospital.
Trust me, Gloria, you don't want me speaking to the press right now.
Or ever.
Look, as much as you ER cowboys are a pain in my ass, what you and your department did here tonight was nothing short of miraculous. People need to know that. Take the win.
Need a second round of MTP.
What the fuck?
Systolic's down to 64 to 38. He's tagged at 132. Pelvic fracture?
Yeah, rechecking for delayed intra-abdominal bleed.
I thought you said he was stable.
He was after 3 units.
And he continued to improve. Pressure got up to 118 systolic after the full MTP.
We hear second round of MTP. Blood pressure is down to 64 with 38. Heart rate is 132. Now, the patient is in shock, obviously. Vitals now worsen than what they were before. Earlier, the blood pressure was 92 over 54, and the heart rate was 120. Now that blood pressure has decreased to 64 over 38, and the heart rate has worsened from 120 to now 132. So at this point in a trauma, if you remember back to various critiques, I have stated things change in emergency medicine. If your patient has a change in clinical condition after you've completed primary survey, for example, you've been given blood, patient's stable, you do all these procedures, patient's stable, and something changes, start back at the beginning with airway, breathing, circulation, and see what changed. Maybe that ET tube is now dislodged somehow. Maybe the patient has a history of blebs in the lung, no previous pneumo, and now with the positive pressure from the ventilator, they actually have a pneumothorax now developing a tension pneumothorax, and you're like, whoa, is he bleeding again? Nobody bothered to listen to the lungs. He actually has a pneumothorax now. Or, despite the pelvic binder, the patient's bleed is now getting worse. Or perhaps Your first fast was negative. Remember when I talked about that, repeat fast exams? Your first fast was negative. Patient's now decompensating. The second fast is now positive. These are all things that you should be thinking about. Things change in emergency medicine.
Dog of 118.
It was 90 after 3 units.
He gave him too much blood and raised his pressure so high that it blew apart the developing clots that was stopping him from bleeding out.
First round of MTP is 6 units red cells, 6 FFP, 6 platelets. That's what we gave him.
Treat the patient, not the protocol. Systolic of 90 is ideal. Robbie, you could teach your residents about permissive hypotension?
Dr. Shen was on this case.
Shen is a resident.
He isn't attending now.
We thought with the long delay in getting him to IR that
He
he...
did not make it to IR. You overtransfused, you popped the clots, and now he's exsanguinated.
A lot of dynamics going on here. They talk about increasing the blood pressure too far and not allowing permissive hypotension, popping the clot. As the blood pressure was increased to 118 systolic, and the trauma surgeon noted systolic of 90 is ideal. I think what she means by that is typically less than 90 is actually ideal. So overall, this is a patient with a pelvic fracture after suffering a crush injury. I'm going to say an isolated pelvic fracture, isolated pelvic injury is really what they're going for with this. Hemorrhaging internally, and they're waiting for arterial embolization with IR, but it's going to be 45 minutes. And the patient's undergoing a second round of massive transfusion protocol. So let's briefly talk about this permissive hypotension when it comes to isolated pelvic hemorrhage specifically. In this setting, I'm not talking about any other hemorrhage. I'm not talking about a GI bleed that's still active, right? We want the blood pressure higher than that. This is a whole different story. I'm talking about pelvic hemorrhage fracture, open book, specifically when referencing popping the clot. Now, according to the University of Arkansas for Medical Sciences and their acute care surgery manual for this same situation, it states, maintain permissive hypotension when able. Systolic blood pressure less than 90. As long as the patient is mentating, making urine, and does not have other signs of end organ hypoperfusion. And they include here cold, model extremities, decreased LOC, rising base deficits, and lactate. Now, our patient was intubated, not for altered mental status, though, related to shock. It was more for the pain, the procedures, and the need for the OR. So it's definitely different in that situation.
Okay, there's no bleeding in the belly. It's too deep in the pelvis to see on ultrasound.
Second round of MTP is here.
Blood and plasma on the infuser. We got him back once. We'll get him back again.
Dr. Abbott states there is no bleeding in the belly and it's too deep to see an ultrasound when referencing the pelvis. Now, I do actually disagree with this. The patient, in this much shock with a pelvic injury, if they had a negative fast earlier, and temporarily they clotted off, they're stable after a massive transfusion protocol, and now they're decompensating, so now they're hemorrhaging, you're going to have a positive fast on this second fast exam. That entire abdomen likely is filled with blood. That entire pelvis is filled with blood. I cannot tell you how many bleeds like this I've had. If you're in this much shock, especially after the massive transfusion protocol, after a period of stability, then you're in shock again, this bad of a pelvic injury, that abdomen and pelvis is going to just be filled with blood, and you would see this on ultrasound. That's actually my only critique with this part, is I think your second fast is going to be positive.
3 grams calcium gluconate.
Why calcium?
Citrate to the transfusing chelates leading to hypocalcemia.
Dr. Ellis mentions 3 grams of calcium gluconate, which is perfect. So what's the point of calcium in a massive transfusion protocol where the patient is getting a lot of blood product? So for this, I turn to the University of Maryland Emergency Medicine Educational Pearls, updated December 28th, 2025. How about that for very up to date? Entitled Optimal Calcium Repletion for Massive Transfusion Protocol. Citrate is an anticoagulant added to blood product to maintain stability for storage. With the administration of large volumes of blood products, citrate binds to ionized calcium, which can cause hypocalcemia, hence you're giving calcium. Evidence for specific calcium administration during massive transfusion protocols is limited. However, a proposed strategy has been to administer calcium gluconate 2 grams for every 2 to 4 units of red blood cells. So just to kind of put that in perspective and to kind of give you a little bit of info of where some of those sources come from. And so in this case, they said 2 grams calcium gluconate for every 2 to 4 units of red blood cells. Obviously in the PITT, they gave 3. It's totally fine. That's awesome. Again, we don't know how much blood they actually gave. They're simply saying here 2 grams calcium gluconate for every 2 to 4 units of red blood cells.
Hey, found Mrs. Chu in the stairwell, smoking.
Oh, good job. Mrs. Chu, tobacco use is not a healthy habit.
I've outlived 3 husbands. Yeah, probably died of secondhand smoke.
Dr. King, we want you to do the spinal tap before Flynn gets any worse.
Great. I will meet you in there.
Yes, love this. Let's do the spinal tap. Now, obviously in this case, we know it's just the dad giving permission, as he used the word we, and it turns out his wife was actually not aware of the situation. But in the consent form for procedures, it's just one parent signing the consent form, so the ER did everything they're supposed to do.
Dr. Shen, nice of you to join us.
Systolic's only 68. After how many units?
3 units in the second MTP.
Total of 9.
This is not looking good, kids.
I'm sorry if I gave him too much blood.
Dr. Ellis, now that Dr. Shen is here, we have plenty of hands on deck. Why don't you go check on your other patients?
Hey, what about REBOA? The balloon cuts off blood to the lower half of the body.
With bilateral crush injuries, we don't know if we have an intact artery to thread it in.
You could always crack the chest, cross-clamp the aorta, and stabilize.
A nurse goes, what about REBOA? Finally, someone at least mentions REBOA. Dr. Abbott states, with bilateral crush injuries, we don't know if we'll have an intact artery to thread it in. This is actually the first time we hear bilateral crush injuries, as this changes everything. To help explain this concept of not knowing if you have an intact artery to thread it in, I want to actually look at a case published by the Department of Orthopedic Trauma and Plastic Surgery at the University Hospital in Leipzig, Germany. We present the case of a 17-year-old female who sustained a severe rollover trauma and pelvic crush injury as a bicyclist by a truck. Upon arrival of the first responders, the patient was awake, alert, and following commands. Subsequent to lifting the truck, the patient became hypotensive and required cardiopulmonary resuscitation, application of a pelvic binder, and endotracheal intubation at the accident scene. She was then admitted by ambulance to our trauma center under ongoing resuscitative measures. After primary survey, it was decided to perform a REBOA with surgical approach to the left femoral artery. Initial insertion of the catheter was successful, but it could not be advanced beyond the inguinal region. Hence, the patient was transferred to the operating room, but died despite maximum therapy. In the OR and later autopsy, we found a long-distance ruptured and dehiscent external iliac artery with massive bleeding into the pelvis in the context of a bilateral vertical shear fractured pelvic bone. This is the limitation the PITT was referencing. Now, the conclusion of their article states, REBOA can be a useful adjunct, but there is a major limitation with potential vascular injury after pelvic trauma. In these situations, cross-clamping the proximal aorta or pre-peritoneal pelvic packing as traditional approaches of hemorrhage control during resuscitation may be the most considerable methods for temporary stabilization in severely injured trauma patients. More clinical and cadaveric studies are needed to further understand indications and limitations of REBOA after severe pelvic trauma. And now, of course, it's time to go through a few comments. These comments I received are from the part 1 and part 2 of episode 14, so we're going to go ahead and go through these now. This first one, really enjoy your critiques. I'm a paramedic student, and even though I only plan on being a medic, I still like learning everything emergency medicine. So thank you for that. Again, a lot of the subscribers to my channel are medical professionals, so that is terrific. That is awesome. I love it. This next one, these videos are so digestible and provoke so many learning points. Signed, a pre-med interested in emergency medicine. Thank you so much for that. All I ask is that you tell all your friends about the channel and they all subscribe. Next one, it's been a long time since I commented, but I just wanted to say thank you for these videos. I'm 1 year into nursing school, and your content really helped me realize that nursing isn't the right path for me. Because of that, I've actually decided to apply to medical school instead. Truly grateful. Thank you so much from Finland. That is incredible that, I'm really starting to get subscribers from other countries. And so I could see that on YouTube. I can see various different countries. And so that's absolutely incredible. Thank you so much. I'm sure you would have made an awesome nurse, but hey, if you want to go into emergency medicine, fully support that. That's just awesome to be able to hear. Dr. Taylor is back at it. The GOAT of the doc reacts. This is terrific. I don't know if I've ever been called the GOAT for like anything, but this is actually pretty cool. I said at the very beginning, I could promise you these are going to be the most in-depth, detailed analysis, critiques, whatever you want to give it. It's going to be more detailed than any ER doctor on YouTube, specifically for the PITT. I would argue, you know, I did the live reaction to Code Black. It was a live reaction, and even then it was very specific. It was very detailed. Obviously not all of the learning points of the PITT because it was a live reaction, but you know, definitely check that out. But the point is, my goal was to make this the most detailed of any doctor on YouTube. And so I'm going to continue doing that even to season 2. Next one, I've been watching your PITT reacts since the beginning, and I have to say that I've become so much more confident in medical terminology and communicating with my doctors. I've been inspired to read more about common conditions and procedures that you explain in your videos. You've turned a greatly entertaining show into a greatly educational show. And so that is absolutely great to hear. Early on with these episodes, they were only 20 some minutes. I think episode 1 was 20 some minutes, and then they slowly got longer to 40 minutes, over an hour. So, you know, the more fun I got to have with it, the more of an outlet I needed. Throughout the series, the episodes started getting longer and longer. So this one's going to be long too. I don't know the length of this one. It's all one episode. So, you know, this could be an hour and a half. It could be close to 2 hours. I don't know. I wanted to take a deep dive into every concept, including the most up-to-date literature. And I promise you from the beginning I was going to do that, and I will not let up for season 2. My goal is to actually go even deeper in season 2. So I'm super excited about it. This next one. Pharmacy technician here. I've been here since the beginning, and getting a notification that you've uploaded always makes me happy. I watched a lot of different channels over the show in the beginning, but no one does it like you. That is awesome. As always, don't forget to check out the shorts on the channel, a new segment breaking down injuries in various cartoon characters as if they were real, including Woody losing his arm in Toy Story 2, Mufasa falling to his death in the original Lion King movie, and of course Clayton hanging himself in Tarzan. So please check out those short videos. Plenty more coming. For those that have not checked out the live reaction to Code Black, please take a look at that. I did think about doing that for season 2 of the PITT, but the truth is I would not be able to cover the same amount of detail. So I'm actually going to continue with the current plan, going in depth. So obviously it's done after watching the videos on a live reaction, but I think if I want to continue that same level of critique, that same level of analysis, that same level of depth, I'm going to continue doing what I'm doing. However, something a little bit different. I am going to be collaborating with a few other physicians from YouTube in season 2 for a few shorts on a live reaction part for individual cases. I'm not going to give you any details regarding that. You're just going to have to wait and see. We're going to keep that a surprise, but I have had a few reach out, and we are going to do a live reaction on a few individual cases. So super excited about that as the channel continues to grow. With that being said, let's get back to the critique.
Order and stabilize.
I got a better idea.
Yeah?
Pre-peritoneal packing. Simple midline incision below the umbilicus, packed like hell around and behind the bladder. That pressure should stop the bleeding until we get him upstairs. Robbie, pre-peritoneal packing. Thoughts?
I've only ever done one in cadaver lab.
Because it's an OR procedure.
We did them all the time at the combat support hospitals.
All right. What the hell? Suprapubic prep and drape, sterile gowns all around.
Hey, let's go. Get on the horn of the OR. We need at least 6 lap pads, the biggest goddamn retractors you got, Devers, right angles, whatever. Saddle up, cowboy. We got this.
Let's talk about pre-peritoneal packing. For this, I turn to an article published in the World Journal of Surgery entitled Pre-peritoneal Packing for Pelvic Fracture Bleeding Control, a Human Cadaver Study. Authors from the Department of Surgery at Emory University in Atlanta, Georgia, University of Kentucky, Chandler Medical Center, University of Southern California State. Pre-peritoneal packing has been widely accepted as a damage control technique for severe bleeding from pelvic fractures, per the University of Arkansas for Medical Sciences in their acute care surgery manual. Studies have reported that only 5 to 15% of hemodynamically unstable patients with pelvic fractures have a target to embolize. Therefore, angioembolization does not address potentially lethal bleeding in 85 to 95% of patients hemorrhaging from their pelvic structures. Authors go on to state, pre-peritoneal packing is an effective measure for early hemorrhage control in hypotensive patients with bleeding secondary to pelvic ring disruptions. Some studies have shown no difference in mortality or ICU length of stay between pre-peritoneal packing and angioembolization. However, there is an overall increased delay to hemostatic therapy and hemorrhage control with angioembolization, especially when interventional radiologist is not immediately available. And in this case, they're not available for 45 minutes.
Dr. Alice, where do you need me?
Back here at 7 a.m. to relieve the night shift.
I can work a double.
Samara, you are a great doctor, but you need to know when to turn it off. Go home.
Oh, Dr. Ellis, the parents of the measles patient have finally consented to an LP, but Dr. Shen is tied up with the trauma.
I can do it.
We got this. Go.
I can work a double. Actually, you can't work a double at all. Per the current ACGME guidelines, it states, while on duty in the emergency department, residents may not work longer than 12 continuous scheduled hours. There must be at least an equivalent period of continuous time off between the scheduled work periods. Now, that's just in relation to emergency medicine residents. I'm not sure offhand if, different residencies have a daily hour cap, if there's some differences there. This is specific for emergency medicine residents. Now, she again is a third-year emergency medicine resident and wasn't aware of ACGME guidelines, so already it's like a red flag, like, how did that miss the cut? Like, if this was an intern saying it, I would totally believe that, because I tried to do that as an intern. I think I tried to do it as a second year too. So it's one of those things where if you're gonna say that, don't make it a third year saying that, like make it an intern or second year. So already, that was already kind of like, it doesn't make sense.
Still doing okay?
I'm fine.
Did you witness any of the shooting?
No?
But, you were found in one of the parking lots.
Yeah.
What were you doing?
They're just hanging out?
Were you with friends?
No.
You can tell me anything, right? I'm here to help, if I can. I had a good friend who went through some really ugly stuff with me. We were young, and someone older was taking advantage of our age. And things got so bad that my friend took her own life. There isn't a day that I don't regret not being able to stop my friend. But there also isn't a day that I'm not grateful I didn't do the same. Life can be so fucking hard. But it gets better. And there are people who can and want to help you with whatever you're dealing with.
This is a solid moment for Dr. Santos. Great for her character. It's just sad it took all the way up until episode 15 to really see her character. This strategy she's using here, it's solid. She has a suspicion that this whole thing was a suicide attempt, and the only way to get the patient to maybe talk about it or admit to that is if she's able to connect with them on a different level. This same concept is utilized in the emergency room all the time. I would have to say the best connections to a patient and their family sometimes is sharing something from your own life. I had a patient last night where the labs and imaging was suggestive of multiple myeloma. We talked for a little bit and I was able to share some of my experience when my mom was diagnosed with that same cancer. When you connect like that, you don't become just another ER doctor that saw that patient and saw their family. To them, you become the doctor that cared enough to share a personal experience. You connected with them. You showed sympathy. You showed compassion. I would argue that is the difference between a good ER doctor and a great ER doctor. Be that difference.
I just don't want to be here anymore.
Then let's have you talk to a professional who can help you with those feelings. So what do you say? Will you talk to someone?
I never thought I would say this in this entire series until now. Great job, Dr. Santos. Great job. And I don't mean that sarcastically, like legit, great job.
Here come more lab pads.
Drop them on the mail.
Template to me. I've done 100 of these.
Just somebody fucking do it.
All right, fine. But just down to the linea alba. I don't want you going down too deep and slicing the bladder.
Thank you for the safety tip.
Matt.
Okay.
Add some forceps. Once I'm through the fascia, you're going to sweep a finger around the bladder, open up the space of Retzius.
Named after Anders Retzius, 19th century Swedish professor of anatomy.
Seriously?
History of medicine is the closest thing I have to a hobby.
You might want to leave that off your dating profile. All right, 3 lap pads on each side of the bladder, deep as you can.
Deaver retractor.
Named for John Blair Deaver, Philadelphia surgeon who revolutionized abdominal surgery in the early 1900s.
Surrounded by med nerds.
I went to med school at Penn. Walked by his portrait every day. Dude did like 100,000 surgeries.
Guys, BP is not any better. Systolic is 72.
What I want to do now is show an actual video on pre-peritoneal packing for pelvic hemorrhage. Now, I will say it's not the best quality at all. It's not the best quality audio, but I still wanted to at least play it here so that you get an idea of what they're actually doing on the PITT. So let's take a look.
Okay, let me see the first pack. Let me see an empty sponge stick now.
The first key maneuver is to drive the pack deep in the pelvis. And that can be done with a sponge stick as shown here, or some can do it with a Cobb elevator. But the key point is to get that deepest lap in the pelvis.
Okay. And you go in your side now. Okay.
What I mean by that is positioning that lap in the SI joint and deep in the sacrum where the venous bleeding is most common.
Get the third lap ready, please.
Now packed both the right and left side in the deep region. We now approach the middle pack. We'll go back to the right side here. And again, using one type of instrument or the other, it's important to tightly pack the second layer against the deep layer. The final layer, the third layer, is placed above this second pack. And once again, it's important to tightly pack this area. We always place 3 packs on either side in adults as per protocol. And in children, in fact, we often will only use 2 packs, depending, of course, on the size of the pelvis. But we have a strict protocol of 3 packs on either side for adults, so that the team removing the packs the next day will know how many packs to anticipate as they remove them sequentially. So in sum, that would mean a total of 6 in adults and 4 in children.
You got a sponge stick to me? Should I see this for a second?
Now, it's important to emphasize that this is a multidisciplinary procedure.
Okay, go ahead, Zach.
Virtually all the time, there is both a trauma team and an orthopedic trauma team doing this procedure simultaneously.
Perfectly in the midline. And the longitudinal view? Right between the vertebrae. Good to go. You're up. Okay.
Is it painful? Will you feel it?
Not at all. He's fully sedated.
Only pausing here to state this scene is unrealistic and that they are doing a sterile medical procedure and nobody is wearing a mask. In real life, for all lumbar punctures, for all LPs, we're gonna have a gown and mask on. If you don't have a gown, you're gonna at least have a mask. Also, the family in this case, the father is just like walking up, no mask on, and starting to ask questions. If you recall in an earlier critique when the PITT showed us ECMO, they all had masks on. Now I understand that mask may hinder the audio, but showing us an LP, nobody's wearing a mask, and then the family just walks up and starts asking questions. Also without a mask on? 100% not realistic.
Enter bevel up. Aim for the umbilicus.
Oh, that's pop.
That's the supraspinous ligament. Enter slowly. Next pop is the ligamentum flavum, and you're in.
Felt it. All right. Removing stylet.
Okay, Dad, we're in. It's gonna take a minute to collect, but the fluid looks clear.
That's good, right?
It's a good sign. The lab still needs to run some tests, look under the microscope to rule out some bad stuff.
Now, before we continue with the rest of the scene, I want to talk about the procedure itself, including a step-by-step video. Now, my critique with this scene is that Dr. Ellis mentions a pop felt for the supraspinous ligament and then another pop for the ligamentum flavum. In real life, you rarely feel those two pops at all. I've done so many LPs over the years, I can't count how many I've done. However, how many of those did I feel two pops? Probably zero, all right? I don't remember ever feeling two pops. How many of those did I feel one pop? Maybe two or three. Again, you may be able to feel that pop of the ligamentum flavum, but you're not relying on that at all. In this show, she just inserts it, feels a pop, then another pop, and then she notes, I'm in. What we're doing in real life is advancing the needle. All right, we're gonna pull out that stylet. We're gonna see if we have cerebrospinal fluid starting to come out. We're gonna advance the needle further with the stylet in, and then we're gonna keep doing that. And then finally, seeing if we have that CSF coming out. We're slowly advancing each time, checking each time. So here, two pops, we're in. It's not realistic in that regard. The rest of the procedure, I don't really have any critique with that. I just wanted to mention these, again, few subtle details here. Now, what I'm gonna do is play a video that is gonna do a breakdown of the procedure step by step. This video is courtesy of MRAP Education, since a lot of the procedures in the PITT actually come from MRAP Education. Let's take a look.
I'm Dr. Jess Mason, and we're going to show you how to do a lumbar puncture. You want to position your patient either in lateral recumbent or, as shown here, sitting upright. This patient prefers to sit upright. Now, either way, you want to have them arch their back and flex at the hip, and that's going to increase the distance between the spinous processes so your needle can more easily fit through. If they're sitting up, you can have them rest their feet on a stool, and then they can rest their head and their arms maybe on a table in front of them. Now, you can also consider giving them a little bit of benzodiazepine to help them through the procedure. Let's take a look at the real procedure done by Dr. Jordan Harp. Whether the patient is upright or lateral recumbent like this patient, identify the landmarks by palpating the posterior superior iliac crests, and where they meet in the midline should be L4, which is good. That's below the termination of the spinal cord, and we don't want to poke the spinal cord, so place a mark at this level. Clean the skin with antiseptic solution, and drape the patient to give yourself a sterile field. Anesthetize the skin with a wheel and then the subcutaneous tissue in the tract that you're planning to pass the needle, and we hope we're right. We know we may have to redirect. While that anesthetic is taking effect, you can get ready, set your tubes up and your manometer if you're going to check an opening pressure. To set up the manometer, take the two pieces of tubing and connect them. That way you can measure pressures greater than 36 centimeters of water. Now we're going to get the three-way stopcock and connect it here. And your spinal needle will connect right here. Make sure the three-way stopcock is open to the spinal needle and to the manometer, so the fluid column can rise up the manometer. Once you're done measuring your pressure, you're going to turn that three-way stopcock so you collect the fluid from the column into your collection tube. Spinal needles come with a stylet in place. The bevel should be oriented longitudinally with the dural fibers. So if the patient is lateral, the bevel is up. And if the patient is upright, the bevel is to the side. Try to stay midline and imagine that you're aiming right towards the umbilicus or the umbilicus or the belly button. Your needle has to penetrate the supraspinous ligament, which connects the spinous processes, and the ligamentum flavum, which connects the lamina of the adjacent vertebrae. So in theory, 2 pops. In an average-sized patient, that needle is going to be inserted about 3/4 of the way. Might be a little farther than you think. Now, it's important as you advance the needle that you're checking frequently if you're in the spinal fluid, because you won't always feel that pop through the ligaments. So remove the stylet and check for spinal fluid, and then advance it a little further. And then remove the stylet and check for spinal fluid, and then advance it a little further. Remove the stylet Now, if you're still not getting spinal fluid after a few tries, you can remove the needle or you can pull it out just to the subcutaneous tissue, repalpate for your landmarks, and insert the needle again when you change angles just a little bit. Insert. And it looks like we're in right here. So I'm gonna ask an assistant, Dr. Whitney Johnson, to come help me out at this point. If you wouldn't mind getting the manometer. And we will set this up right here. Would you hold the top for me? And you can see the fluid column starting to rise up the manometer to give us a pressure. Once we have our pressure measurement, we're now going to collect the spinal fluid from the manometer into our collection tube. So you turn the stopcock to open it up. And once it's drained out from the manometer, you can remove the manometer altogether and continue collecting your spinal fluid. This LP was pretty difficult, and we ended up having to sit him upright to get spinal fluid. Normal CSF is clear. Try to collect a few milliliters of spinal fluid in each tube for testing, and remember, don't aspirate spinal fluid. Replace the stylet before removing the needle, and that's it, folks. That's an LP.
What are you doing? You said she didn't want to be in the room. I was getting Georgia something to eat. Wait outside. Stop what you're doing right now.
No, they're almost done.
I can't believe you went behind my back.
I did what was best for Flynn, not for you.
Take that needle out of his back.
No.
Yes. Ma'am, I don't want to have to ask you to leave. Take it out right now. Yep, coming out. All done.
I honestly thought she was gonna quickly come in, Google something, and then run over and take the needle out herself. I was waiting for it. I was for sure that she was just gonna come in and just rip out that needle.
My son is leaving this hospital.
I'm sorry. She really is a good mom.
Again, ADEM from measles carries a 10 to 20% mortality. Measles can be dangerous. ADEM is dangerous. And the MMR vaccine is, guess what? Not dangerous.
In place?
Yeah. Number 6 and we're done.
Okay.
BP 92 over 48. That's good enough for me. How much blood so far?
Up to 5 on the second MTP.
No more unless he tanks again.
Sounds good.
Hey, I'll stay with him until IR's ready.
Okay, by yourself?
Yeah, need to make sure he doesn't get another drop of blood.
You're not needed in the OR?
Nah, it's ortho surgeries all night long now. Hey, you okay?
Yeah. He's just tired. I think we all are. Holler if you need us.
I will.
The patient is now stable after the preperitoneal packing, basically providing tamponade until IR can take the patient for angioembolization with IR. Now, I'm not going to get into the procedure itself because that's done by an interventional radiologist, including my friend Dr. Jamison Wilson. That procedure is outside of the scope of emergency medicine, but I at least wanted to make mention of the procedure in this situation.
Why are you still here?
Almost done. Where's the cops? Arrested Doug Driscoll.
Good.
I want to know if I want to press charges.
Yes.
I just want to forget this whole fucking day.
Me too. But you still have to press charges.
Yes, you should press charges relating to her getting assaulted and getting punched in the face. Violence in the hospital is not accepted. Violence against healthcare workers is not accepted. You will be arrested. You will be prosecuted. This is a felony offense.
Have you heard anything about me today? Just like any kind of rumors?
So do you care about rumors about you or anybody else?
I don't. It's just something I heard that Langdon told me that he heard from the night shift nurse.
Yeah, well, there's a reason we stick them on the night shift. Hey, I'm kidding. You want to tell me what it was? I'll tell you if I heard something.
No, never mind. Can you find the remaining day shift so I can do a debrief before we all go home?
Yeah.
Is Jake still here?
Yeah, he and Mom are in North 3 now.
Dr. Robbie, I think you need to look at this
done.
kid. You're gonna want to see this, trust me.
I got this.
What am I looking at?
14-year-old girl playing with her older brother takes a fall as her older brother chases her up the stairs after she stole a forkful of his takeout. Told you not to see it.
When I was a resident, I was just like Dr. Ellis here with getting excited. In this particular patient, I would love to know what the triage chief complaint was. Fork in the nose, fork through the nose. In some of these cases, the chief complaint they state may say private or foreign body or medical screening exam or just something else pretty vague. When you actually click into the chart, you get to actually see the triage note where sometimes whatever the patient stated, the nurse is going to put in quotes exactly what they said. As long as it's in quotes, you're good. You can literally say whatever you want in there in terms of what the patient said, just put it in quotes, please, because sometimes you get patients come through, their chief complaints got, numerous swear words in the thing. Just put it in quotes. But when we read some of these are entertaining. I'm actually going to put a few of those on the screen for you. And these are actual chief complaints of triage notes that I've collected over the years. During my chief year in residency, I utilize these for some of my more entertaining lectures. A patient comes in, they state whatever to the nurse as the reason that they're here, and the nurse puts it in quotes, and that shows up, and then when we pick up that patient, we get to see that. So that's what these are for. Of course, all identifiers are taken out, so we're in compliance with HIPAA. When we see something like this, any resident or attending is gonna pick that case up as fast as we can. As a resident, the better the chief complaint, the better the triage note, the faster that case is going to be picked up. Now, unless you're actively dying, unstable vitals, that's a different story. Coming as a stroke, a heart attack, gunshot, that's a different story. In kind of a stable setting, stable patients, nothing really new coming in, and something checks into the ER and it's got one of the chief complaints I mentioned, patient checks in, chief complaint in the board says rectal foreign body. You're gonna click that chart open so fast, you're gonna assign yourself to that patient so fast. It's literally gonna be a competition, residents fighting for that particular case. Patient comes in, it says rectal foreign body. You click on the triage note and it states in quotes, so the patient told the nurse puts it in quotes. I was in the shower with a vibrator. I left it in there by accident and somehow I slipped on it and it went straight up my ass. What? Right? We're gonna pick up that case so fast. We know you didn't slip and fall on a vibrator and it went directly straight up the rectum. All right? The x-ray on the screen is that patient. That was my case. Do you know how fast I picked up that case? I kept hitting refresh on the board so that I can assign myself to that case so that nobody else picked up that patient. And then once you pick up that patient, you go up to your attending and be like, hey, can I staff this with you? Every single time that attending is gonna say yes. In fact, they're gonna say yes before you even finish that sentence. And so we'd go up and be like, hey doc, I got a patient with a rectal I'll take it. Go ahead and put my name on it. That's what happens every single time. And so what's actually cool about this is literally Dr. Abbott stands up and goes into the room. Again, such a very small detail, but this happens. This is like spot on. So sometimes we need a bright spark in our day, and a rectal foreign body may just be enough to give us that bright spark. A vaginal foreign body may just be enough as well, or in this case, a fork through the nose may just be enough.
This is Dr. Shen written all over it. Don't worry, we're bringing in our utensils specialist.
I can keep a straight face through most things, but stating utensils specialist, I'm not sure if I could actually keep a straight face saying that. What was actually interesting, or what was, very unique about COVID is that you wear a mask obviously all the time in the hospital. So I finished residency in 2019, and then of course COVID hit that following year, early 2020. And at that time, everybody has a mask on all the time. When you go into patient rooms, you got a mask on. You can really hide that expression. And so there's a few times where, based on what the patient's saying, I'm a brand new attending, what the patient's saying, I'm like, thank God that I had a mask on. And so obviously since then, patients can literally tell me whatever and the face is just gonna stay straight. Now in this case, utensil specialist, I haven't heard that before. It's actually really funny.
We're gonna start you out with some nasal numbing spray for the pain. Do you mind if I take a photo for the medical record?
Wow, I was so disappointed with this part of the encounter. She is a senior resident and smiling at the situation. That is already inappropriate. Your patient is scared, the family is scared, and you're smiling. Are you f***ing kidding me? You cannot smile, smirk, regardless of what that chief complaint is, or, what's going on. You need to maintain that straight face. What she does, she smiles, pulls out her phone, and says she is taking a picture for the medical record. Well, that's a lie. And then she puts patient identifying information on her phone. Wow, all I can say to that. That is illegal. That is a HIPAA violation to put identifying information on your personal phone without patient consent. This is definitely identifiable, all right? It's literally her whole face, and she gave no consent of any kind, including any verbal or written consent. You can tell the patient's clearly scared. Mom is scared. She is a senior resident, and she's worried about an image. Well, she's more worried about this image than comforting the patient, than comforting her family. Is this realistic? Meaning, does this happen? I'm sure it does, but it should not happen. Now, we do have apps that actually allow us to put images in a patient's chart. You open the hospital app on your phone, you pull up the patient, their chart in that app on your phone, and you take a clinical image. All right, that picture uploads into the patient's chart. It's not saved in your phone. That is part of the medical record. It's done entirely through the app. There's also like a dozen clicks you need to do before you actually get to the point of taking a picture. So here she's asked, if she could take the photo, never got permission, just quickly took it. What the senior resident did was not just unprofessional, it's a significant HIPAA violation, a poor representation of an emergency medicine resident, someone that lacks integrity, lacks empathy, and if this was found out, it would result in disciplinary action. This is crazy. This is ridiculous. You're a senior resident. If this was an intern, yeah, all of these things would still, be an issue. But the further that you get along in your residency program, the more that's expected of you. And to be a third year or a fourth year, that's unacceptable.
All right, everybody, listen up.
You got it, Cap.
Today should never have happened. It's impossible to imagine what would possess somebody to commit such a horrific act. It's the worst of humanity. But it brought out the best in the rest of us. We saw our better angels come to the aid of our patients. Each of you rose to the occasion. And I can't tell you how proud I am of all of you. This place will break your heart. But it is also full of miracles, and that is a testament to all of you coming together and doing what we do best. Thank you for everything you did here today.
Emergency medicine is truly a group of individuals, each with a different task, coming together in the midst of organized chaos to save a life. Dr. Robbie stated, this place will break your heart, but it's also full of miracles. That is a testament to all of you coming together and doing what you do best. So for the most part, in the emergency room, we are seeing people on the worst day of their life. For others, it's their best day, and frankly, they look forward to their multiple visits to the ER. They, like frequent flyers, will meet up with each other, but for others, it is the worst day of their life. Some come knocking on death's door. A child comes in, CPR in progress after drowning. Someone took a nail to the heart. Someone is having a heart attack. Another was in a serious motor vehicle crash. Another was electrocuted. One suffered a fall, a life-threatening burn. For all of these patients, we are here for you 24 hours a day, 7 days a week, 365 days a year. This is what we do. This is emergency medicine. This is real ER medicine.
We saw 112 mass casualty patients come through here in the last 4 hours. And 106 of them are going to live. None of us are going to forget today. Even if we really, really want to. So go home, let yourselves cry. You'll feel better. It's just grief.
Leave me the body.
I cannot tell you how many times I've had a shift that was so bad, it affected me so much that when I got home, I just hugged my daughter. The last time I did that, she goes, "Daddy, what's wrong?" And I simply said, "Nothing, Bella, I just wanted to say I love you." In one of my previous critiques, I talked about a case I had in my very last year of residency involving a child that died after a large wooden dining table fell on her head as the family was moving, and this table was in the process of being taken out and is leaning up against the wall. The patient suffered an open skull fracture, was undergoing CPR when she arrived at the hospital. At that time, the child was the same age as my daughter, and it affected me so much, I went into the bathroom and cried before going to see another patient. It does not matter if you're an ER nurse. It does not matter if you're an ER doctor. Sometimes you need to go home. You need to go into a quiet place and just cry. There's nothing wrong with that. We may bring back people from the dead in the ER, but we are only human.
You want to grab a drink?
Yeah. Yes. When?
Now. Oh, some of us just get a beer in the park across the street.
Oh,
Helps to download before you go home.
okay. Sure.
Mom!
Hey, buddy, you're still up.
Yeah, me and Grandpa just started watching Planet of the Apes.
What did I tell you about scary movies?
That's fine.
This is actually a pretty powerful scene and an array of emotions and expression. We can tell she is thinking to herself, this might be my last shift. Awesome job on the PITT for portraying something like this without even saying a word.
Look at it, someone who made the same decision you did.
I could have kept him for a few more days on ECMO.
You gave him a fighting chance. And then you used the limited resources we had to give that little girl a chance.
You lost them both.
Yeah, but you did your best. We all did. Hey, he would have been proud of you for what you did and for everything else since then. Come here. You wouldn't let anyone else blame themselves for this. Time you gave yourself some grace.
See you Monday.
Nice moves, right?
What the hell are you doing up here?
What the hell are you doing up here?
Just 1 second. Okay, I will, on occasion, after a long shift, crash here.
This was your first day here.
Well, it's my first day of emergency rotation. I did internal medicine last month.
Do you actually have a place to live?
I'm currently between places.
Do you own a car?
Not at the moment, no. I'm actually...
Between cars.
Yeah, something like that.
Okay, so I have a spare room with its own bathroom.
Sweet.
Oh, for God's sakes, do you want the room or not?
Okay, that is extremely generous, but no, I can't afford to pay you rent right now.
How are you at cleaning and fixing things?
Grew up on a farm, I'm guessing pretty handy. Cleaning, I know how to muck out a stall.
Just keep to yourself. Don't annoy me, and you can move in.
Wow, I don't know what to say. Thank you.
Well, you can move in tonight if you want.
Really?
Yeah, but quick before I change my mind.
Yeah, no, I mean, this is all I really have, so.
Oh, God, you're not some, like, nudist or religious freak, are you?
No, I like to remain fully dressed at all times, except bathing.
I know Krav Maga.
Cool. I don't know who that is, but he sounds very protective of you.
The chances of this working are diminishing by the second.
What?
I'm just fucking with you, Whitaker. You're such a huckleberry.
There is just so much truth to this scene. Whitaker is a fourth-year medical student. For those not familiar with how medical school works, it's a 4-year program for your doctorate. The first 2 years are didactic, so it's in-class teaching, hands-on stuff. You get some practice with procedures, a few different kinds of, labs. Now, for me, those first 2 years were in Arizona. Now, for your 3rd and 4th year medical school, we call this your clinical rotations. Every medical school is going to have a hospital or a set of hospitals that are contracted with them to take on medical students as you rotate through each specialty. Literally, internal medicine, family medicine, OB, general surgery, the list goes on. You do this for 2 years. Now, for many students, emergency medicine is actually a 4th year rotation, which is what Whitaker is doing. So again, very small detail here, but to have him going through emergency medicine and to be a 4th year is impressive. Now, could Whitaker do that as a 3rd year? Yes. All right. There's certain instances you do that, and also depends on the medical school itself. I will say at the end of my 3rd year, I did my first month in emergency medicine. So really end of the 3rd year, beginning of the 4th year. Now, I went to Midwestern University in Arizona, and what I'm going to do is I'm actually going to put a few numbers on the screen for you. It was expensive when I went through it, and it continues to increase every single year. Again, terrific school. Love it. Would do it again. But what I want to do is I want to put some numbers. These are public numbers. This is right off the website. So I took some screenshots of these and I'm going to put them on the screen for you. You're going to notice tuition for a 1st year. All right. Disability insurance, student services fee for a total of $82,672. All right. For 1 year. Then on top of that, you're going to see living expenses. So books, supplies, personal equipment, housing, off campus, on campus, etc. Total cost $33,012. Guess what? 1 year of medical school. Obviously, every medical school is different, state versus private. Now, these numbers are higher than when I went here in 2011, but I simply wanted you to be aware. Now, depending on your background, family, personal situation, you can clearly see why paying this amount for 1 year, let alone your 2nd, 3rd, and 4th, believe it or not, oftentimes those numbers increase the further that you go. So you can imagine paying that much money is going to deter people from going to medical school at all, from going down that route. Now, I didn't join the Air Force until medical school was over. So I was in the same boat as Whitaker here during medical school. My rotations were all over the Midwest, literally traveling from Arizona to the Midwest with predominant sites throughout Illinois and Michigan. I remember doing a month of emergency medicine my 4th year, and I stayed with one of my best friends and his family to save on money. As a medical student, you don't get paid anything. So as a medical student, you're broke, let alone now you're traveling the United States for a rotation and you're needing a place to stay. Now, on a personal note, to change it up a little bit, sharing it here with my audience, I was the first member of my family to go to college, let alone to get a bachelor's degree, a master's degree, doctorate, and all the training that followed. I would do it all again without question, without hesitation, in a heartbeat. The advice I have for those wanting to pursue a career in medicine is persistence. If you keep fighting, if you keep going, if you keep knocking down obstacles, you're gonna make it. My dad worked in a factory, mom had high school education, grew up in a small town. We didn't have anything. Growing up like that, you can imagine the negativity of people saying you're not gonna make it. Prove the undergraduate counselor wrong that said you would never make it as a physician. It's too hard. Continue to ignore all the negative people that tried to bring you down. If you do all that, you may end up graduating top of your class, working in multiple trauma centers at multiple different hospitals, serving your country in the Air Force, and be critiquing medical dramas for fun on YouTube.
I know that this is difficult. This is gonna hurt for a long time. And it's okay if you wanna blame me. Just please don't blame yourself. We've been friends a long time. I would hate it.
No, we're not friends. And you're not my father, so fuck off.
Jake.
Robbie. Parents of Jake's girlfriend, Leah, are here. I put them in the viewing room.
Wow, if things couldn't get much worse for Dr. Robbie, he's already been beaten down, he's at the end of his shift, and he finds out that the parents of Jake's girlfriend are now in the viewing room or consultation room, and he has to go talk with them. At this point, it's just putting the nail in the coffin. If you remember when I discussed compassion fatigue in an earlier critique, regardless of how many patients you've seen in this one shift, regardless of it being a mass casualty event or not, this family deserves your everything. They deserve your compassion, your honesty, and your sympathy, as if this was your first patient of the day and your first family discussion of the day. It is not walk in, tell them she passed, sorry for your loss, and walk out. This is that moment that myself, I would really try to focus to pull that last little bit of energy that you have for just one more conversation. Such an emotionally charged and powerful moment. For anybody in emergency medicine, you know exactly what Dr. Robbie is feeling right now. It is palpable. It will give you flashbacks. It will break you if you let it. This is what the PITT does. It can take an ER doctor in real life, make him feel as if he's at work. That is the power of the PITT. That is the power of the greatest medical drama of all time.
Hey, Boca.
Hi, Mel.
You ready to go?
Yep. All right, let's go.
Let's go.
It's dark out.
Oh, yeah. Sorry about that. I had to stay a little later than expected at work.
Because of your boss?
Oh, no. A bunch of people got hurt at a music festival.
And you had to help them?
Yeah.
We're supposed to go to a restaurant on Fridays.
We could still go to a restaurant.
It's not too late?
Not for us King sisters. Where do you want to eat?
Pizza. Or spaghetti. I don't know, I can't decide.
Well, why don't we do both?
Both?
Yeah. We can go out for spaghetti and then take a pizza home with us.
Really?
Yeah, why not?
Can we still watch a movie?
It is Friday, isn't it?
Elf!
Yeah. We can do Elf. Or we could see a movie that we've never seen before.
But Elf is so fun.
I love Elf. It's actually one of my favorite Christmas movies. A few years ago, I did a YouTube video on my other channel, Physicians for Wishes, where I gave Christmas presents to an entire elementary school in need. The school we went to had a large economically disadvantaged population, with many of the children going to go without Christmas presents that year. We worked with the principal and all the teachers to do something so incredible, so awesome. It was probably honestly one of my favorite wish videos that I've ever done. Once the presents were bought, wrapping them was an entire different issue. Way too many to wrap with just a couple people. So I actually had the help of my Dance Dad Elf team. Every year, Wishes Dance Studio puts on a Christmas performance, and the dads function as Dance Dad Elf. So yes, I am a dance dad. So the day we wrapped, all the dads were in our dance costumes, and we did skits in the video mimicking the Elf movie. It was so much fun, so many laughs. Please check it out. Check out that entire video. Again, I'm gonna put a little bit on the screen for you, and I'm gonna put a link in the description. It will truly warm your heart. With all the negative in this world, sometimes we just need that smile. Sometimes we need to hear something good for a change. And sometimes you realize how much of an impact you can make with just one act of kindness, regardless of how big that is, or regardless of how small that act of kindness is.
You're in my spot. Just so you know, Grubhub will not deliver to the roof. But there's a DoorDash guy, Marco, who will trek up here for an extra $10, 20 if you want beer. Nice speech down there. Wish I had given it.
No, you don't.
No, fuck no. But glad somebody did. Yeah. I think I finally understand why I keep coming back now. It's in our DNA. It's what we do. We can't help it. We're the bees that protect the hive.
Maybe you, not me.
What are you talking about?
Damn well what I'm talking about. I broke.
You didn't break. You didn't break.
I shut down. The moment everybody needed me the most, I wasn't there. Couldn't do it. I choked.
For what? For 40 seconds? 3 minutes? 10 minutes? So fucking what? We all have that. That is what happens when you're in a war and nothing makes sense. Well, we survived as a species because we learned how to cooperate and communicate. So when we're in the middle of killing each other, it defies the very logic of our existence. Your brain starts to short circuit. All you can do is focus on the medicine. The medicine's the only thing that saves the patient and your sanity.
I'm gonna need a drink if you keep talking.
You get what I'm saying, right? You rock that shit down there tonight. Yeah? You rocked that shit down there tonight. We all did. Now that is a compliment. Accept the damn compliment for once.
What if we just didn't talk for a minute?
I'm just trying to help.
I know.
I appreciate you.
Still talking.
Sorry. Get that drink now?
Yeah.
I remember one really bad night shift, only physician on, running in one room, coding a patient, running in another room, coding another patient, going back and forth between two patients, each in cardiac arrest. You find out you're getting a trauma 1 coming in through the front door, stroke patient just arrived into the next room via EMS, a pediatric patient just came in that's in so much respiratory distress and they're getting sleepy and they're gonna need intubated. Literally, all of these patients come in one time. You're the doctor. It's you. That trauma patient needed intubated, chest tubes, and a massive transfusion protocol. The CPR was still going on in the one room, and I go back and forth between all of them. The trauma ended up going to the OR. The one cardiac arrest, I got Ross, so I got that pulse back and went to the ICU. The other I pronounced, so now there's a family discussion with that one. The stroke patient ended up getting TNK. The pediatric patient ended up being intubated. In the middle of all this chaos, all of that, was an elderly patient in his 80s that would walk to the edge of the curtain, look out, see the commotion, hear the commotion, and then go back in the room. He would go back out and then would go back in, hearing all the noise, the monitors, seeing all the running, hearing cries of family members, seeing the chaplain walk by, watching everybody walk by. He would just keep doing this. At the end of all of this, I stood in the hallway taking a breather. All the patients have been dispoed. I'm just in the hallway taking a breather. He comes out. Hey doc, I didn't want to bother you by hitting my call light. You all were really busy, but do you mind if I ask you something? And I'm like, sure. And he goes, why do you keep doing this? I paused, took a deep breath, and said, I do it for that chance to save a life. He goes, yeah, but it seems like you get burned out like this. I respond with, oh, I am burned out. We're all burned out. But to be part of an emergency trauma team that can bring back someone from the edge of death, it's hard to put that into words, just how that makes you feel. And the hope is that that feeling then trumps that part of you feeling burned out. You're taking one positive and so much positive that it's kind of outweighing that negative. That's the goal there. And he just kind of looked at me. Okay. When you get the chance, do you think you'd get me a blanket? Absolutely.
Whoa. It won't take long to fill up in here. Never does. How long until we run out of boarding beds? Holy sunrise.
She had a seizure.
Of course she did.
Looking good, Dr. Abbott.
You too, man.
Hey, fruitcake.
Fruitcake, don't ask. When are you coming back?
I don't know. Grab a couple hours sleep, come back around 2.
I don't think they're gonna need relief until the morning.
You know me, I prefer working nights.
You're not sick of working nights yet?
My therapist thinks I find comfort in the darkness.
Oh.
I'll give you his number if you ever feel like talking to him.
Does it help?
I haven't jumped off the roof, have I?
Not yet.
What I love about the PITT is the awareness they are bringing to mental health. It is truly incredible. The emotional side of the emergency department, the toll it takes on residents and physicians and nurses, the PTSD, the trauma, it's absolutely amazing for the PITT to be able to demonstrate that. I really hope they continue to bring awareness to mental health in season 2 and continue to cover some more topics to enhance that awareness, that there is help, there's people to talk to, that someone does care for you, that someone does love you, and that we are here for you.
Hey, hide the hard drugs, kids. Oh, nice catch. Oh.
Today was a motherfucker. Have you ever been in anything like that before?
Let's hope none of us ever has to again.
No shit.
We probably will. If not us, others.
Yeah, but we survived that craziness, right? To the PITT crew.
To all the people we saved.
Here.
And the ones we couldn't.
And, well, to doing this all again tomorrow. Cheers.
Is this where all the cool kids hang out?
Oh, you know it.
Nice of you to join us.
If there ever was a day. Actually, sorry, I don't drink. I don't know why I took that.
She's not old enough.
I'd say if she's old enough to put her in a chest tube and intubate, she's old enough to drink a beer.
We won't tell your mom.
Shut up. But seriously, don't.
Thank you.
Guys do this after every shift?
Not always.
Usually it's a little more lively. But the emergency department throws wicked parties.
What's so funny?
I just realized this is your first shift.
Yeah.
That was baptism by fire, baby. I can pretty much guarantee you the next one will be easier.
I really fucking hope so.
Hey, at least you didn't get pissed on.
I will drink to that.
Aw, poor Whitaker.
Yeah.
Where is he?
Yeah, probably quit.
Aw, that kid's tough. He'll be back. Just like the rest of us. Okay, that's it for me.
Beer for the road?
Yeah, why not? Good night. Get some rest. Tomorrow's another day.
How about that for an awesome season 1? As an ER doctor, I can honestly say this is the best TV medical drama of all time, in my opinion. While not 100% accurate and not 100% realistic, and with a few concepts throughout the TV series that were medically wrong, it's still the greatest TV medical drama of all time. Welcome to the start of an awesome journey as I critique TV medical dramas. There is no Hollywood doctor here. There is no Princess CPR here. Welcome to Dr. Taylor Reacts, and welcome to real ER medicine. Next up, season 2, let's go.